Okay, everybody, this is part 3. Let's bring it home with platelets and some coagulation disorders. So it's important to rule out any platelet disorders for children that are going to surgery, anything extensive, and for any children with known petechia, frequent nosebleeds, any bleeding of the mucous membranes, or any excessive bleeding for minor traumas. It's important to assess for any family history of any bleeding disorders and any history of drug or toxin abuse. Your initial labs will include a CBC and a platelet count, a PT, a PTT, and if you're concerned about a platelet issue, it's always important to request that your labs be drawn in a blue tube or a citrate tube, because as platelets will be sticky and clumped together, if that happens, then your platelet count may be adversely low, and a citrate tube will keep those platelets from clumping. Some other diagnoses that may be on the table might include ITP, hemophilia, von Willebrand's, and leukemia. So let's first talk about immune or idiopathic thrombocytopenia purpura. It's the most common platelet issue that is seen in childhood, and it's believed to be an autoimmune response when circulating platelets are destroyed. It usually occurs after a viral illness, and in often cases it can be an autoimmune condition. In peds, it most often occurs between 1 and 4 years of age, and oftentimes they may resolve on their own within 6 months without any treatment. But if a ITP lasts longer than 12 months, it's considered chronic and needs to be evaluated for any associated diseases that can be seen with it, and those might include leukemia, side effects of medications such as quinine or heparin, lupus, cirrhosis, HIV, hep C, and some congenital causes such as X-linked thrombocytopenia, autosomal macrothrombocytopenia, Wiskott-Aldrich syndrome, and von Willebrand's syndrome. So on your clinical findings, your diagnosis is going to be made based on your lab values, and it's typically made when platelets are less than 20,000. There may be an acute onset of petechiae or purpura, which is the reddish rash that can be on large areas, or even known bleeding. You may see kids with more increased bleeding from the nose when they brush their teeth, even could note blood in the urine. Seen after a recent viral infection, as we talked about, hemorrhage of the mucous membranes, nosebleeds, for young ladies that are starting their periods, heavy periods, are known to happen with ITP. You may not see any hepatosplenomegaly or lymphadenopathy, and there's rare that there's any bone pain or paleness to the skin. So the test may show a low platelet count, but severe thrombocytopenia is considered after 20,000. You may see a normal PT and a PTT. You may see megathrombocytes on the peripheral smear. You'll have a normal WBC and an RBC. If there has been some issues with bleeding, though, your hemoglobin may be on the lower side. Other differential diagnoses to include could be hemolytic uremic syndrome, DIC, or a lymphocytic anemia. So management of these patients' prognosis is good. If your platelets are greater than 20,000 and there's no hemorrhage, the importance is safety, and you're going to need to have the patient and the parent avoid any contact sports, any roughhousing, tumbling, things like that. It's important to avoid aspirins and NSAIDs. If platelets are less than 20,000, you might be try to do a steroid challenge and treat them for about 4 days with steroids, or even use IVIG if bleeding is severe. That's not what you would do, but that is what treatment may be. If you did have platelets that were less than 20,000, I would recommend that you refer to a pediatric hematologist, or at minimum consult with your consulting doctor. Splenectomy may be used for the management of this, and immunosuppressive medicines for refractory or chronic ITP. So one of the biggest complications, of course, is going to be bleeding, and that could be intracranial bleeding. So I would recommend, as I do with my adult patients, that if there's been any falls or any occurrences where the child has hit their head, that requires an immediate follow-up, and require, if you can't get into your doctor, would require a ER visit to have a CT to assess for any intracranial hemorrhage. Let's talk about hemophilia A and B and von Willebrand's disease. These are both inherited coagulation deficiencies. Most result in abnormal bleeding issues. So in your hemophilias, you have a deficiency of factor VIII, which is hemophilia A, and factor IX, which is hemophilia B. So with these hemophilias, you can have spontaneous or prolonged bleeding from small vessels as a result of trauma. So factor VIII binds with von Willebrand factor in the plasma and acts as a carrier protein. In type 1, the protein is quantitatively reduced, and in type 2, it is qualitatively abnormal, and it's absent in type 3. Because the genes for coagulation factors are sex-linked and they're carried on the X chromosome, and recessive hemophilia A and B affect primarily males, females are generally only carriers of the disorder. There's a good table, 27-10, that gives a comparison of hemophilia A and B and von Willebrand's disease. And then also there on box 27-3. Disregard that last line. I'm not finding a fibrin clotting cascade in the book. Some clinical findings that you'll find for these diseases are a positive family history. The patient or family member may report excessive bruising or any prolonged bleeding. You can have hemothrombosis, which is bleeding into the joints, prolonged PTT time, and there are some specific assays for factor 8 and 9 that you can order to confirm. Management includes prevention of trauma, replacement therapy if necessary, cold and pressure to affected joints to help prevent increased swelling, and there's a strong interdisciplinary approach to managing hemophilia. Complications include brain hemorrhage, anemia, and hypovolemic shock. As you may be seeing some of these kids in practice, the National Hemophilia Foundation has published recommendations supported by the Medical and Scientific Advisory Council on their recommendations on the website, and the guidelines are available in a publication regarding management of von Willebrand's disease. So thrombophilia is the increased ability to form clots, and that is usually associated with acquired or inherited risk factors. We know that thrombotic events are rare in healthy kids, but needs to be assessed if there are inherited thrombophilia traits known. And these may include a factor V Leiden mutation, protein C deficiency, protein S deficiency, antithrombin deficiency, and prothrombin 20-21-10 mutation. Let's next talk about some white blood cell disorders. We know that our white count is an indicator of infection or illness, and that percentages of our differentials, the monos, basos, segs, lymphocytes, and eosinophils are useful diagnostic information when we're looking at a CBC. We can see WC dysfunction related to infection, illnesses, and malignancies. So the first thing we're going to talk about is some alterations in granulocytes, and these are your neutropenia, your neutrophils, also called segs. So when you have neutropenia, or that decrease in your neutrophils, you have decreased number circulating around. There is a formula that you can use to calculate your absolute neutrophil count, but and most labs do put that on there anymore, but anything greater than 1,500 would be considered normal. Mild compromise would be anywhere from 1,000 to 1,500, moderate 500 to 1,000, and severe less than 500. And neutropenia is often severe with chemotherapy. Alterations in lymphocytes are often produced by viral illnesses, and these could include the mumps, the measles, rubella, varicella, mono, hepatitis, pertussis, and CLL, chronic lymphocytic leukemia, can also raise the lymphocyte count. Next, let's talk about cancer in children. It is uncommon and often presents with symptoms of a benign illness. Signs and symptoms may include unexplained weight loss, headaches, typically early in the morning, swelling or persistent bone or joint pain in the back or legs, mumps or masses, excessive bruising, bleeding, or rashes, consistent infections, persistent nausea and vomiting, tiredness, vision changes, fevers with no etiology. Pediatric cancers can differ from adult malignancies in both prognosis and tumor site. The most common types of cancers in children from birth to 14-year-old are your ALL, your acute lymphocytic leukemias, cancers of the brain and central nervous system, tumors, neuroblastoma, non-Hodgkin's lymphoma. And then in adults, Hodgkin lymphoma, thyroid carcinomas, brain and CNS tumors, and testicular germ cell tumors are the most common cancers in adolescents. So the incident mortality and survival rate for children is based on race and ethnicity. In contrast to adult cancers, kids with cancer, only a small percentage have been known to be caused by something that was preventable. Ionizing radiation is a well-known risk factor. And as healthcare providers, it's important that we limit CT scans in children and pregnant women to those that absolutely need it. So we're going to talk briefly about leukemia, which is just change in the circulating leukocytes, and lymphomas, which are solid tumors that are lymphocytic in nature. So in our bone marrow, we have normal cells that produce for our white cells, our red cells, and our platelets. And leukemia is when we have an abnormal, poorly differentiated cell that develops, that's usually not seen on a differential, called blast cells. These are lymphocytes that have a genetic abnormality, and they take over and result in proliferation of malignant cells. And so leukemias are based on and classified according to the cell type of involvement. Most common form in children are ALL, acute lymphocytic leukemias, at 80%, and AML, acute myelogenous leukemia, at 15%. Most of the clinical signs and symptoms of leukemia are related to the replacement of these cells in the bone marrow. So you're seeing repeated infections, fever, weight loss. You can have history of bleeding, bleeding noses, petechiae, hematomas. You can see swelling, lymphadenopathy in the neck, the armpits, and the groin, and you can have hepatosplenomegaly as well. And then there's bone and joint pain. The first diagnostic tests that you're going to have complete are your CBC with a differential that includes platelets. You're going to run a reticulocyte count. You're going to look at a peripheral smear to see what the pathologist will, to see what cells are there. These are kids that when you see these issues on the CBC, you're referring to a pediatric oncologist. A bone marrow aspirate will next be performed to see what the bone marrow is looking like underneath the microscope. And then also there will be checking chromosomal and genetic abnormalities. The management of these patients is quite good. 90% have a 5-year survival rate. Treatment will include chemotherapy with 4 to 6 weeks of an induction chemo, followed by a consolidation phase of several months, and then 2 to 3 years of maintenance therapy. Stem cell transplant is considered after second remission. There is a leukemia with a Philadelphia chromosome, and that may bump someone up on the stem cell transplant option sooner. With AML, you have an induction. They do get CNS prophylaxis as part of this chemotherapy. The idarubicin does cross the blood-brain barrier, and then there will be post-remission therapy. Long-term things to worry about include cognition, neuropsychological function, growth deficiencies, and then as these kids get older, there's always an increased risk for second malignancies. So lymphomas are broken up into two categories, non-Hodgkin lymphoma and Hodgkin lymphoma. First, we're going to talk about non-Hodgkin, and they're a diverse group of solid tumors of the lymphoid tissue. And so there's been a malignant proliferation of T cells and B cells. In pediatrics, the most common are based on the type of cell, and it can be a Burkitt or a non-Burkitt subtype. There's also lymphoblastic lymphoma and diffuse large B-cell lymphoma. Clinical findings are going to include a tender abdomen and non-tender lymph node enlargement. Diagnostic tests are going to include a CBC and an LDH, a uric acid, electrolyte levels. You may see a CT, MRI, and a PET scan to help with staging of the disease. Management includes definite multidisciplinary approach. This individual is going to need to be seeing a pediatric oncologist, will be started on chemotherapy. In kids, traditionally you are not using radiation, as the kids are very receptive to the tumors, very receptive to the chemotherapy, and radiation is not commonly used in pediatrics. And the survival, 5-year survival rate is over 85%. Hodgkin's disease is a malignancy of the reticular, endothelial, and lymphatic system and involves B cells. It originates in the cervical lymph nodes and spreads to the other lymph systems, and if untreated, will spread to other organs, including the liver, spleen, bone marrow, and brain. Other clinical findings may include a chronic cough, fever, decreased appetite, weight loss, and night sweats. You'll be assessing for anemia in these patients. You'll assess for a SED rate and a CRP. You'll look at ferritin levels, abnormal LFTs, proteinuria. They may have ultrasounds of these lymph nodes, CTs, MRIs, and PET scans for staging. Treatment is done at a major pediatric oncology center, and then they will have lifelong monitoring for side effects. Lastly, we're going to talk about the late effects of childhood cancers. It's estimated that between 1 in 530 young adults between 20 and 39 years old is a long-term cancer survivor, and with that means that there needs to be good assessment for adverse effects that may be related to chemotherapy. These late effects can be attributed to radiation therapy, chemo, or a combination of both, and can occur later during puberty and later in life. Some of these conditions can include short stature due to cranial radiation, precocious puberty due to cranial irradiation, avascular necrosis of bones related to steroids, osteoporosis, leukoencephalopathy, peripheral neuropathy based on some chemotherapies, cognitive dysfunction, stroke, and seizures related to intrathecal chemo, vision, auditory, and skeletal changes related to head and neck irradiation, and then there can be obesity and gonadal dysfunction due to the neuroendocrine effect. More include altered pubertal developments related to alkylating agents for chemo, cardiomyopathies related to anthracyclines, pericardial effusions, pneumonitis, malignant glioma, secondary leukemias, glomerular and tubular injuries, infertility, cystitis, psychosocial effects, and a cancer relapse. I believe that is the end of this chapter, and I don't know about you, but I'm tired. I hope that it's given you some good information, and we'll discuss more of this in class. But that's all of part 3. Thank you.